Hello, everyone. This is your host, Mehak Shah, and welcome to another episode of Heart Success Podcast, where we discuss practical knowledge and the latest in the field of heart failure, cardiovascular medicine, cardiac hemodynamics, right heart failure, pulmonary hypertension, and thoracic transplantation. Today's topic of discussion is going to be the role for medical and device therapy when it comes to sudden cardiac death in heart failure and reduced ejection fraction. We'll be focusing a lot more on the medical aspect of things, doing device therapy at a later episode with an electrophysiologist. Progressive pump failure accounts for about a third of cardiovascular deaths in patients with heart failure, and the remaining two-thirds are commonly attributed to sudden cardiac death. It is well known that patients with heart failure and reduced ejection fraction have at least a 6 to 9-fold increase in the rate of sudden cardiac death when compared to the general population. We will focus on the role for medical therapy, anti-remodeling, anti-fibrotic agents, neurohormonal antagonists, and briefly go over the role of ICDs in preventing sudden cardiac death among patients with HFrEF. To start this conversation today, we have a guest with us. It's Dr. Nasrien Ibrahim. She is an assistant professor of medicine at Harvard Medical School and the associate director of resynchronization and advanced cardiac therapeutics program at Massachusetts General Hospital in Boston. Dr. Ibrahim completed her internal medicine residency and general cardiology fellowship at the University of Cincinnati Medical Center in Cincinnati, Ohio, following which she completed her fellowship in advanced heart failure and cardiac transplantation at the University of Colorado in Denver, followed by fellowship in clinical research at the Massachusetts General Hospital, where she retains a faculty position as an advanced heart failure cardiologist. Dr. Ibrahim's research involves heart failure, including biomarker research, and she participates in several clinical trials aimed at improving the management and outcomes of patients with heart failure. We are excited to have her on this episode with us, and before we went on and had this conversation, I did get her permission to call her by her first name. When I was editing this audio, I realized that parts of the conversation has the sound of wind in the background, so I apologize for that. Welcome to Heart Success, Nasrien.
Thank you for having me. I'm excited to talk to you today.
Thank you, Nasrien, for accepting this interview. Could you tell us something about you for our listeners? You are an early career advanced heart failure cardiologist. Maybe a word of advice for future cardiologists and other early career cardiologists like myself.
I would say the most important thing is goal setting. So figure out what you want to do, and I find it very helpful to write down my goals and envision what I want my career to look like. I feel like oftentimes, fellows and early career physicians like myself, we are usually, under the wings of our mentors, and sometimes we find it difficult to break away and find the things that we actually love to do. So I think it's important to define what you personally like to do and what you envision your career as, and then set goals for yourself. And as you crush those goals, find new ones. And that's how you keep advancing in your career. And again, having mentors that you really trust and connect with on a personal and professional level has been instrumental to my early success. And so I recommend finding people that you jive with really well to guide you on this, complicated but really incredible journey.
Thank you. That's terrific advice. Certainly I'm going to take some notes down on what you said and follow it in my practice. One of the things I wanted to discuss with you was, fighting burnout and fighting work-related stress, not just for trainees, but even for professional and people in their early careers or late careers. You wrote a perspective piece titled Physician, Heal Thyself about a year ago. Could you maybe share some insight from that piece and something from your day-to-day life that helps you deal with burnout and work-related stresses?
I think the most important thing, and a thing that I have made a priority since I was in medical school, was to always have a life outside of medicine. So, I want to kill it while I'm at work and with my research and clinically, but I also want to have a very good life outside of medicine. And actually, a lot of my friends are not physicians. And so that gives me a mental break away from talking about patients, talking about research, about deadlines. So I think first and foremost is to have hobbies and things that really feed your soul that are outside of medicine, because it gives you that break that you need, but also learning to set boundaries. So especially early on in the beginning, if you're someone who, works really hard and writes papers really fast, and you start getting these opportunities, and it's amazing to get all of these things handed to you, but you also have to set boundaries, because nobody, can work without a break, and, we're not robots. And so setting boundaries, I usually think of three things. Am I passionate about it? Is it going to promote me in my career, or is it going to pay me? And then that's when I decide if I'm going to pick something up or not, to take on. And then, there's systematic things that we can't control, like the computer systems and all of this, but really communicating to your team members, to the staff that's helping you when you're on vacation, this is your time away, or that you don't need to be on unnecessary emails. So all those things are part of creating boundaries and really protecting yourself, because we can't take excellent care of our patients and we can't do excellent research if we're not doing well inside. And I think the first thing is to create your boundaries and also find what you love to do outside of clinical medicine and keep doing it.
Thank you for that advice. Our topic today is to discuss sudden death in heart failure. This topic has made a bit of a comeback recently, especially in the last few years, with newer therapies coming out for heart failure, including your angiotensin receptor neprilysin inhibitors and your SGLT2 inhibitors. So the topic has seen maybe a sort of a revival. We will be addressing where sudden cardiac death stands in heart failure and reduced ejection fraction today. This may be a timely topic in certain ways, because I've been reading a lot of papers on how sudden cardiac death has changed over the years in heart failure.
Yeah, and it's certainly a really exciting time in heart failure because of the new therapies that you mentioned, the ARNIs and the SGLT2 inhibitors. And we know we're not doing a good job based on, the CHAMP-HF registry, that we're not really putting our patients on these guideline-directed medical therapies that have an enormous benefit on reduction of cardiac death. And so, we think of these things, when I think of the meds, it's low-hanging fruit. You're talking about a beta blocker, an MRA, an ARNI. We're not talking about things like LVAD and transplant that can, prolong life. We're talking about medications that, when used appropriately, have a significant impact on the reduction of cardiac death in our very sick and complex HFrEF patients. So it's a really exciting time that we have these options, and that hopefully we're going to keep developing more therapies for patients with HFrEF.
One of the things historically I have always thought about when we talk about sudden cardiac death is arrhythmic death in patients with heart failure or heart failure reduced ejection fraction. So maybe we could spend a little time on defining what sudden cardiac death truly means among patients with heart failure.
Certainly. So the original definition of sudden cardiac death was actually based on people just in the general population with no known heart disease. And it was defined as demise within an hour of onset of new cardiac symptoms. So as you can imagine, when this definition is applied to the general population, it's really hard to, extrapolate and say that this is the definition we're going to use with patients with a known cardiac condition such as HFrEF. And so when researchers first described sudden cardiac death in HFrEF patients, they said it was an unexpected death. So a patient that's seemingly doing okay, with no obvious triggers and no clues, maybe just sitting at a desk job, suffers an unexpected death. That was considered sudden cardiac death. And then later on, there was development of prediction models and, data from large clinical trials. And so they said that the definition of sudden cardiac death would not apply to patients with an extremely limited life expectancy due to stage D or end stage HFrEF. So that we would say sudden death only occurred in patients that we expected to live, months or years from when we had met them. But patients that are very frail and end stage who do suffer sudden cardiac death, we should rethink how we're defining those patients. And then also, as with anything, each individual patient is different and the mechanism of sudden cardiac death is different in each patient. For the most part, it's presumed that sudden cardiac death is because of ventricular tachyarrhythmias such as VT or VF. Bradyarrhythmias and PA occur less frequently, and most of the time you see this in patients with non-ischemic cardiomyopathy. And then even a witness cardiac arrest doesn't necessarily have to be because of VT or VF. It can be a sudden mechanical or vascular catastrophe such as a PE or vascular rupture. And so really important to understand the underlying substrate in each patient.
Mm-hmm. And like you said, we really do need to separate the etiology. Maybe if we were to use large categories as arrhythmic sudden death and non-arrhythmic sudden death, which you compiled were some of these other etiologies. A recent paper I read, I think it was Milton Packer, who's published several papers in this field on sudden death in the last year or so. And he discussed what causes sudden death in patients with chronic heart failure and reduced ejection fraction. He revisited some of the old and touched upon topics, but also introduced some relatively new concepts in approaching the etiology for sudden death. I was wondering if maybe we could talk a little bit more about some of these newer concepts in sudden death that have developed maybe in the last few years.
And that's an excellent paper, actually, for anybody that takes care of HFrEF patients or is a heart failure cardiologist themselves if they have not read that paper. But he talks about different mechanisms that make HFrEF patients prone to sudden cardiac death and lethal arrhythmias. And, the main one that we think about is left ventricular remodeling. In this case, the ventricle is dilated, it's fibrotic, and there's scarring in the ventricle that is a good substrate for ventricular tachyarrhythmias such as VT and VF that can cause sudden cardiac death. In certain cases, there's an identifiable trigger, whether it's an MI, which causes a surge in sympathetic activity, or any electrolyte imbalances that can cause sudden death. But a lot of times there's no precipitating mechanism. It's just sudden circulatory collapse. There's also this concept of genetic predisposition that has been shown in several population-based studies, including the Paris Prospective study. So if a patient had one parent that had a history of sudden cardiac death, their risk increased by 80% of having a sudden cardiac death themselves. And if both parents of the patient had a sudden cardiac death, then the risk for the patient to have a sudden cardiac death was 880%. And so it's important to think about the different mechanisms of death because, for example, in a severely remodeled fibrotic heart, the first incidence of a VT or a VF might be responsive to a shock by an ICD. However, on the other hand, when you have an arrhythmia like an asystole, a bradyarrhythmia, or electromechanical dissociation, or incessant VF, such a sudden cardiac death really can't be prevented by an ICD. And when we talk about the remodeling and the fibrosis, that's when we really have to think about our guideline-directed medical therapies because that's what they do, the neurohormonal blockade and the CRT. The point is to reduce remodeling, left ventricular size, and reduce fibrosis, which all contribute to tachyarrhythmias.
Yeah. With this topic of non-arrhythmic death, really was introduced the concept of self-organizing criticality and cascading heart failure, which you briefly did touch upon. What does this really mean for patients with heart failure when we're looking at non-arrhythmic deaths?
And so I was actually introduced to this concept after reading this paper. I really hadn't heard of it before. And so when you think of this self-organizing criticality, it happens in complex system. And heart failure with reduced ejection fraction is a complex system. And so there's small events that trigger a major catastrophe. And all of these pathophysiologic pathways are interdependent. And the process, as we know, heart failure is a chronic disease, so it's an ongoing process. It's tolerated for a long period of time. And then these different mechanisms, they self-organize. And once they reach their limit of stability, that's when we get this cascading failure. So all of a sudden, everything is in place until it reaches a limit. And again, the patient falls apart, essentially, is how I think about it. That's when we have to think about whether or not a patient's going to respond to our guideline-directed medical therapies, whether they're medications versus CRT, or we need to think about the next step. So important to figure out how do we prevent the patient from reaching this point of self-organizing criticality.
And I think this perfectly lines up the next question is what do we have in our armamentarium today that we can use to help these patients? One of the things we do discuss in a lot of these patients, is introducing guideline-directed medical therapy, which usually includes the neurohormonal blockade agents. What different, I would say, drugs and non-medical therapies in your practice would you go to provide maybe some advantage in reducing the risk of sudden cardiac death?
Yes, and I'm so glad you asked me this question, because really one of my biggest pet peeves when I do a multidisciplinary clinic with electrophysiology and heart failure is seeing patients that are referred for an ICD and they're on 5 milligrams of lisinopril, for example, and 12.5 milligrams of metoprolol succinate, and now an ICD is requested because that patient clearly is on very low doses of guideline-directed medical therapies, which is really doing a disservice to the patient, because we do have a lot of things we can do before patients reach the point where they would need advanced therapies. So the first and foremost, I'll talk about CRT, so cardiac resynchronization therapy. It has striking benefits on ventricular remodeling. And again, so we remodel the ventricular size is small, and now we've removed the substrate for any acute electrical cascade. So therefore, we're reducing the risk of sudden death. And even with CRT alone, without an ICD, the risk of sudden death is decreased by about 50% in certain patients. There is a concept that we talk about a lot about CRT non-responders. So think of these patients when I see an echo with an EF of 10% and the ventricle is 8 to 9 centimeters and the walls are thinned out. I call this like a blown out ventricle. These patients probably not very likely to respond to CRT, but you don't know. And a lot of times you have to give patients the benefit of trying a therapy like CRT before saying they're going to be non-responders or before sending them for advanced therapies. So the benefit of CRT in these blown out ventricles is not as great as somebody with a better substrate for CRT, but nonetheless, it's worth a shot. Another link that we talk about with ventricular remodeling is neprilysin inhibition, and the only neprilysin inhibitor we have on the market is sacubitril/valsartan. And there's a link between sacubitril/valsartan, left ventricular remodeling, which was just shown recently in PROVE-HF, where patients had significant improvement in ejection fraction and reduction in the left ventricular end diastolic and systolic diameters. And then, of course, in PARADIGM-HF, we saw a significant reduction in sudden death. But notably, when patients are on sacubitril/valsartan and they have an ICD, the risk of sudden cardiac death is the greatest, where it's over 50% risk reduction. And so the things that we have to think about when we meet these patients with a new cardiomyopathy, or maybe this is an old cardiomyopathy, but you're the heart failure doc and you're looking at the meds and they're not optimized. So number one, we want to improve the size and function of the left ventricle. But secondly, which is even more important, we want to reduce mortality, and then we want to improve symptoms. So going over the different classes of guideline-directed medical therapies, we'll start with beta blockers. So when you put a patient on beta blockers, and I think it's important to tell patients these numbers, because when you explain to patients why you're giving them so many classes of drugs and explain to them that each drug has a different pathophysiologic mechanism, I think they're more likely to be agreeable to stay on the medicines and join you in your efforts to, again, push these meds to target doses. So beta blockers alone have decreased the risk of sudden cardiac death by about 35 to 45% in large clinical trials. And most of these patients in the trials did not have ICDs. And when you think of beta blockers, so why do they have such a profound effect on sudden cardiac death reduction? It's because they help the reverse left ventricular remodeling process, but beta blockers also prevent ventricular tachyarrhythmia. So that can be another mechanism of why they reduce sudden cardiac death. Another class of medications that patients with HFrEF should be on is mineralocorticoid receptor antagonists. And the risk of sudden cardiac death in these patients is 20% in patients with chronic HFrEF. And also, this reduction was seen in patients that didn't have an ICD. The risk reduction is most, very striking in patients that were already receiving beta blockers. And why are MRAs so great? They reduce fibrosis, but maybe also the reduction of hypokalemia and resulting ventricular tachyarrhythmias is reduced as well. Lastly, ARNIs, like we mentioned before, neprilysin inhibition in Paradigm HF, the landmark trial, sudden cardiac death was reduced by 20%. And I had mentioned previously that patients that had ICDs, the risk was decreased by 50%. We talked about CRT, also risk reduction by 50% in patients, particularly the patients that were already on a good background of medical therapy. There is an excellent slide by Greg Fonarow that talks about what happens when you put patients on all the therapies. So the guidelines say beta blockers, MRAs, and ARNI. The guidelines don't say SGLT2 inhibitors yet, but if you put patients on those 4 classes of drugs, the cumulative mortality relative risk reduction is 73%. Absolute risk reduction is 25.5%, and the number needed to treat is only about 4. So really, not putting patients on the appropriate guideline-directed medical therapies and pushing them to target doses is doing them a great disservice. We have, like you said, a great armamentarium of meds that we can use.
No, that's a fantastic point. I have been preparing my patients for this 4th medication by telling them that soon they're going to be on a new medication that targets another pathway for reducing, to a great degree, sudden death. I know, at least so far, I have not been using SGLT2 inhibitors among the non-diabetic heart failure patients. Do you think there is a role for SGLT2 inhibition in also further reducing sudden cardiac death in these patients?
I think so, and I too haven't been using it in non-diabetic patients, but certainly all of my heart failure patients that are diabetic, we have switched or added SGLT2 inhibitors to their background of diabetic therapy. Of course, we let their endocrinologists know that we're doing that. I actually think SGLT2 inhibitors are cardiac drugs, not endocrine drugs, but that's a whole other conversation. But I do think potentially that they would be helpful in reducing sudden cardiac death. In the EMPA-HEART CardioLink 6 trial, patients were receiving empagliflozin versus placebo, and the ones that were on SGLT2 inhibitor had a reduction in LV mass. Again, these patients were type 2 diabetics and they had stable CAD. So if we're going to extrapolate and say, improvement in LV mass, which means, potential for LV reverse remodeling, and how that's tied to sudden cardiac death, and if we can improve those parameters, then I would hope that, future trials will show that there is a reduction in sudden cardiac death with this class of medications, which will be remarkable for our patients. Hopefully we can make them live forever, but I like that we'll have a lot of options.
And, I think we'll be releasing this episode after the current diabetocardiology series. So hopefully our listeners, if they've listened to that series, will be very familiar with all these different classes, especially the SGLT2 inhibitors, which we spent a great time talking about. So thanks for that little pointer on the SGLT2 inhibitors. I have a couple of questions, maybe more related to the practical part of your practice. So like you mentioned, titrating medications is such a big part of heart failure treatment. How do you do that in your practice? And maybe do you have a structure in place that helps you do this in a faster manner, I would say, in some patients?
So I think utilizing my RNs and my NPs has been the thing that has been most beneficial to me in titrating medications. Because again, these patients are very complicated. Nobody wants to come to the doctor's office every 2 weeks for titration. So we've had to be very creative about how we're going to titrate. I usually make it a goal that when I meet a patient, that by 3 months, maybe 4 at most, that I will have reached either the target doses of all the GDMT or the maximum tolerated for that particular patient. So I utilize my RNs to help with, phone calls. And then we give patients lab slips so they can get their labs checked locally. And if the patient has a blood pressure cuff at home and access to local labs, there's really no need to bring them in and see them. So in the beginning, I probably see them once a month for the first, 4 months until we get them where we need them to be. But in between that time, we're doing, remote titration via phone calls, messages through our electronic health record. But that way we get to the target doses faster. And then if it's a new patient at that 3-month time point, we get another echo and then we decide if the patient needs an ICD or CRTD at that point. But it's utilizing, all the resources you have. Telehealth also is a great way to do remote titration. And at the American Heart Association scientific sessions, Akshay Desai is actually going to be presenting some data from his hospital about a remote titration system that they created to get patients to the appropriate GDMT. And then, of course, most important is to involve the patient. Tell them why you're doing it. Tell them you want them to feel better, to live longer, reduce their risk of sudden cardiac death, keep them out of the hospital. So when you really engage the patients, they're motivated too to get to target doses. I find sometimes the patients are like, Doc, are you sure we can't go up to 97/103 dose of sacubitril valsartan? I'm like, no, your kidneys don't like it, or your blood pressure is not tolerating it. So really helps to motivate the patients when you explain to them why we're doing what we're doing.
You brought a great point on titrating these therapies, especially getting them on the ARNI for maybe an advantage over the ACE inhibitors and ARBs for reverse remodeling. Are you commonly switching your patients to Entresto before, let's say, ICD candidacy? Even if they're optimized and
even if you're on 40 of lisinopril, I do not care. I will switch you to sacubitril valsartan, get you to either the target or the maximum dose, and then after that, I'll make the decision about the ICD, because really the data from PROVE-HF was remarkable in terms of the reverse remodeling that happens with sacubitril valsartan. And if I can avoid an unnecessary ICD in a patient, I will do that. So I really think, again, it's a class 1 indication. There's no reason a patient should not be on sacubitril valsartan. There has to be a really good reason for people not to switch from ACEs and ARBs to sacubitril valsartan.
Yeah, no, even in my short practice, I've had patients coming in for evaluation for heart transplantation, and just getting them an Entresto seems to have really improved not only their cardiac function, but their functional status in a lot of patients. So clearly, in a short span of time, I've seen a lot of benefits come from this medication. Yeah, I'll switch to a couple other questions. So does your approach differ maybe among ischemics compared to non-ischemics when you're doing these titrations?
No, not at all. I treat every EF 40% or less the same in terms of the guideline-directed medical therapy titration schedule that I'm using. We know non-ischemics respond quicker and better, but I treat both all kinds of HFrEF the same.
Mm-hmm. And you brought up a very, very good point. The CRT heart failure clinic, where heart failure and electrophysiologists collaborate to help some of these heart failure patients on CRT therapies. Could you tell us maybe about how this clinic is executed at your institution? Because we certainly are talking about getting this at our institution. We haven't actually started doing this, but we were thinking about maybe having one place where both the heart failure and EP physicians would see patients, maybe one after another, and try to work on different aspects of their care to sort of come up with the best plan for these patients. So how are you guys actually executing this clinic right now?
Yes, I got involved in the CRT clinic about a year ago, and I think it's been very helpful to patients. We try to do as much as we can to reduce the burden on our patients. So if it's, one-stop shop, one appointment, you see an electrophysiology attending, a heart failure attending, we also have an EP nurse, a heart failure nurse, and then we have medical assistants. And so the patient stays in the room, and we as physicians and nurse practitioners rotate through to talk to the patients. But it's a one-stop shop where me as the heart failure doc, I can optimize their medications, decide whether, we can change some things to make them feel better, increase or reduce their diuretics, those heart failure kind of things. And then the electrophysiologists take care of CRT and optimizing the device. We also have the ability to do echoes when the patients come in for their appointments. So it's really nice because, again, it's easier for the patient. We're communicating directly with each other, the EP and the heart failure side of things. And then also it's an opportunity to pick up patients that are CRT non-responders, the ones that are optimized on GDMT. We've done what we can with CRT and they're still not getting better. So those are the patients I can identify, and then I can see them in the transplant and VAD clinic so we can start the advanced therapies evaluation. So it's been really gratifying, and I think it makes the patient's life easier, which we all want to reduce the burden on our heart failure patients. I think multidisciplinary care is the way to go with these complicated patients.
No, I might actually steal your idea there and propose it to my team here, because that sounds really good. One place, and then we actually, by turn or in order, go and see the patient, talk about different aspects. I love that. Yeah.
Yeah, and sometimes you can go in together, because sometimes the questions are similar. And then we also have reps that come and do device checks in the clinic. And like I said, we have access to echo. So it's a really valuable clinic where you can also bring other heart failure devices through the clinic and clinical trials. So it's a really good setup for a multi-D clinic.
I wanted to spend the last few minutes of our conversation today talking about preventing sudden cardiac death, primarily usually arrhythmic death, the VT, VF that we were speaking about. So before I go into the ICDs, do you use life vest in your practice in any patients or a subgroup of patients to prevent arrhythmic sudden death?
Yes. So we know the data says that, using a life vest is not helpful, but I actually think that this should be an individualized decision. So if I'm meeting a patient in the hospital and they have what I had described earlier as a blown out ventricle, a 9-centimeter thinned out ventricle, it's a new diagnosis, and we are going to try guideline directed medical therapies to see if we can improve them. But I look on the telly and they're having lots of ectopy despite being on a beta blocker and maybe amiodarone. So yes, in that patient, I'm not going to send them home without a life vest. In a patient maybe that I'm meeting and their EF is, 28 or 32 and they're not having ectopy and their ventricle doesn't look as dilated, I may say, I really don't think a life vest is necessary. So it's just important to remember the kind of patients that I see, because I'm an advanced heart failure doc. So I'm really seeing the sickest of the sick. So probably my use of life vest is higher than a general cardiologist. But I really think the decisions should be individualized.
Very true. It depends on a case-to-case basis. Talking about ICDs, and we will have a separate episode where we get the EP physicians also to defend their stand. But the trials that have really demonstrated the efficacy for ICDs were conducted 10, 15 years ago. During this time, we weren't using the guideline-directed medical therapies in heart failure reduced ejection fraction like we do today. There's several data points showing there has been a progressive decline in sudden death independent of ICDs, mainly because of these medications that we spoke about, and improvement in the myocardial substrate, reverse remodeling. So the randomized control trials that were done support the use of ICD in improving all-cause mortality, especially reducing sudden cardiac death in patients with heart failure and reduced ejection fraction, whether they're ischemic or non-ischemic. What in your practice is the role for ICDs today in reducing sudden death in heart failure?
So I'm glad you brought that point up, that all the trials were done before we had all of these amazing new drugs like the RNEs and the SGLT2 inhibitors. But does that mean I'm going to stop using ICDs? Certainly not. But it's important for physicians to remember that ICDs do not address the process of cardiac remodeling. CRT does, but not ICDs, and the effectiveness of an ICD depends on the degree of remodeling. And an ICD can only treat the events that result from an isolated electric cascading failure. So again, these patients with the blown out ventricles with incessant VT or a PARS, an ICD is really not going to do much for you. And again, look, we need to remember the numbers. So a patient with ischemic cardiomyopathy and only mild symptoms of heart failure, ICDs reduce the risk of death by about 60 to 70%. The magnitude of the benefit actually declines to about 50% in patients with non-ischemic cardiomyopathy. And then it's actually only, 25 to 30% in patients with moderate to severe heart failure that have these severely remodeled hearts and most likely require advanced therapies. Do I think I'm not going to use ICDs anymore? Not at all. I mean, even with the addition, hopefully in a few, maybe, a couple years of SGLT2 inhibitors to the list of meds we can use to reduce sudden cardiac death, I don't think we can completely get rid of ICDs, but I do think that medications are first line in reducing the actual underlying substrate. ICD is just, your life jacket, your backup plan in case things are not working with your medications.
Absolutely. I recently brought up at a meeting that maybe, I know it's not just me, but on Twitter there's several trains of thought saying maybe we need to conduct these primary prevention trials again, and that did not go well with a lot of folks. So
I know. ICDs are like the bread and butter of electrophysiology, but I do agree that we should have trials now with, our armamentarium of guideline-directed medical therapies and whether or not we really do need ICDs in every patient with an EF 35% or less, or it's a certain substrate that needs the ICD.
And like you said, we're going to have an electrophysiologist come in one of our future episodes and really discuss sudden death from their standpoint, really get their opinion and their expertise on this as well. So do you use other imaging techniques in your patients with heart failure? Do you use maybe MIBG scanning or cardiac MRI or PET scanning in any of these patients?
I get a cardiac MRI on every new heart failure diagnosis. That's not the standard of practice, and that's nowhere in the guidelines. But I like the cardiac MRIs because it can give me information about things, maybe infiltrative cardiomyopathies that may have been missed otherwise, and also a sense of how sick the heart is, how much scarring there is, maybe how thinned out the walls. Sometimes you can see that on echo, but I really think the information from MRIs is valuable because it gives me a sense. Again, you get this sixth sense when you see all these patients that are with advanced heart failure. You get a sense of, are they going to do better? Are they not going to do better? Do they have LV non-compaction? Are they going to respond to GDMT? So just to get a sense of how sick the patient is and how sick the ventricle is, I do like to get cardiac MRI on mostly everybody that I meet. And maybe a PET if we're concerned about an infiltrative cardiomyopathy that's, the read on the cardiac MRI is equivocal.
Mm-hmm. What is your approach to patients with heart failure and midrange ejection fraction? These are usually patients that have an EF maybe 35 to 50%, 40 to 50%, that really categorize neither into HuffPath, which is 50 and above, or HuffRef, usually 40% and lower EF, because we know that the risk for sudden death is lower in this group of patients.
Yes, so patients with an ejection fraction less than 50%, and I would say, so with 40% or less, to me, it's straightforward. I'm going to put them on all the GDMT for HFrEF. But it's, again, the 40 to 50% range that's not clear. And unfortunately, in the U.S. at least, sacubitril/valsartan is not indicated, and insurance companies will not cover it for anybody with an EF greater than 40%. And so in that case, I would use, an ACE inhibitor or an ARB if they have room with blood pressure. And I'd also put them on a beta blocker. Again, this is not data driven. It's just a matter of, in my mind, I'm thinking 50% or less, I would treat more like HFrEF, than I would, HFpEF, which in that case, with HFpEF, you're treating all the comorbidities. You're really just diuresing them. But 40 to 50% is tricky. Maybe eventually ARNIs will be indicated for that range, but as of yet, I use beta blocker, ACEs, and ARBs for the 41% to 50%.
And to that point, I think if I remember the data right, for Paragon heart failure, when they did the subgroup analysis, those with an EF of less than 57% seem to have benefit. Of course, it's secondary analysis, only hypothesis generating, but clearly, like you mentioned, maybe for patients that have a low normal or mildly reduced EF, clearly I think Entresto may have some role. Thank you so much. That was a very comprehensive review on really medical therapy and what sudden cardiac death really means in heart failure and reduced ejection fraction. Thank you so much for your time and coming on to our podcast, sharing your expertise with us. Would you like to, any last minute pointers or plugs or recommendations for our listeners?
No, thank you very much for having me on here. And I would just say, please, please, please put patients on GDMT and don't just stop at putting them on it. Push the meds as high as you can to reduce mortality and morbidity and really just make our patients feel better. I don't want to transplant and VAD everybody. So GDMT is a way for us to prevent that.
Sounds great. Thank you so much for your time, Nasrien.
Thanks for having me.
If you enjoyed our episode, don't forget to like, subscribe, and give us a high rating, as it helps other listeners find us. You can leave your suggestions for topics, critiques, things you think we can do better. You can email us at heartsuccessteam@gmail.com. You can actually find us on our website at www.heartsuccess.info. Our website now also provides links to all the podcast providers where you can listen to this episode. You can find us on our Facebook page at Heart Success Team, or you can always reach me on Twitter at CardioBro.